First of all, thank you to Dr. Jumian and the panel and everybody for allowing me to present this case. And this is actually a case that happened just around the Shock Symposium time last year, and I didn't get a chance to bring it last year, unfortunately, as I couldn't make it. But I wanted to talk to you guys all about a case that happened in Canada, of all places. So I don't really have any disclosures except to say that I am Canadian. And all that means is that even my own patients don't want to pay for my opinion. So I'll tell you about a 60-year-old gentleman who had an orthotopic heart transplant for non-ischemic cardiomyopathy about a year and 3 months before I encountered him during my interventional fellowship. And his initial year had been complicated by just mild cellular rejection and cardiac allograft vasculopathy. So in the fall, about 4 months before we encountered him, he came for his annual left and right heart cath, and you can see that he does have some disease starting in his right coronary artery, which is dominant and quite large, and that he also has some left-sided disease, particularly in his LAD. Now, after his angiogram here, no other physicians were consulted, and the interventional team wasn't consulted about any of his disease, but he was switched to sirolimus and continued on medical therapy, and the patient overall continued to feel very well. A few months later, 5 days prior to his admission to hospital, he started to develop some chest and arm discomfort for about 2 hours. And after that, he actually continued to feel absolutely okay. He didn't call his coordinator, didn't call anybody. But a couple days after that, he started to develop worsening dyspnea, orthopnea, and PND, and he was pretty familiar with those symptoms from his previous non-ischemic cardiomyopathy, and he eventually presented to the ER in the middle of the night. So this was his ECG in the ER at about 3 in the morning. And he was seen by the cardiology team, he was seen by the cardiology fellow on call, and in fact his case was reviewed with the attending on call, and at that point the patient had already diuresed 1.5 liters from a bolus of IV Lasix that he was given from the ER, and his dyspnea had improved. The decision making on overnight, the team on call decided that they could put him as the first case the following morning for urgent angiogram. His troponin was mildly elevated, so they started him on treatment for acute coronary syndrome. They also gave him a dose of solumedrol for presumed rejection, and then planned him for the first case, which is about 3.5 hours later. So the cath lab team admitted him, so the cath lab team came to pick him up at the bedside at just before 8 a.m., and he had a PEA arrest right in front of them, requiring 15 cycles of CPR continuously. So that was a downtime of 30 minutes right off the bat. So the first question becomes, well, what is this guy's prognosis at this point, after he's already had a downtime of 30 minutes? So he's had an in-hospital arrest requiring prolonged CPR for greater than 20 minutes at this point. And if we look at the literature, already his mortality rate is extremely high, with survival rate in this population at less than 1%. So we did not have a formal shock team at the time, but because it was the first thing in the morning, there was a lot of bodies around, and the heart failure cardiologist on call, the interventional team on call, which included myself, and that's how I encountered the patient, and the treating team were all at the bedside, including cardiac surgery, and had a quick discussion already 30 minutes into CPR, whether this patient would, number one, be a candidate for retransplant if we were able to stabilize him, and would he have a viable exit strategy on mechanical support? And all of the providers agreed that he'd been doing very well up until this point, and that a potential MCS insertion would be beneficial, at least to allow a bridge to some sort of therapy. So he had VA ECMO cannulated at the bedside by the surgical team and was taken directly to the cath lab. So you can remember that his RCA was dominant and pretty large before. It's included at this point. And even more concerning is when you look at his left side, he has severe distal left main disease, unoccluded LAD, and pretty much every territory is suffering. What for me is the most concerning in this is you can see the backflow of contrast going right into the LV, showing that he literally does not have any contractility, or at least not enough to overcome the back pressure from the ECMO. So we were able to wire where we thought the LAD was, and we're able to wire the other major branch there also. And after our initial first balloon, you can see that he went from absolutely pulseless to that first ballooning of the LAD started to regain some pulsatility. So we went on to do a VA ECMO. Sorry, that went backwards. So we went on to do a VA ECMO-assisted DK crush procedure of the left main, and this was the final result here. You can see that he did suffer quite a hit to his left ventricle. His LV function, which had been previously normal prior to his admission, was severely reduced, and he was taken urgently to our critical care, intubated and on ECMO support still. So Swan-Ganz was inserted at that point, and the patient's wedge pressure was well above 30 milliliters of mercury, so he was taken actually just right back to the cath lab and had an intra-aortic balloon pump inserted. He was on multiple inotropes and pressures at this point as well. But interestingly enough, his inotropes and vasopressor requirements quickly decreased, and he was off all drips at about 48 hours. His ECMO was decannulated day 5 post-arrest, and he had his intra-aortic balloon pump removed on day 8. He was completely neurologically intact at that point, thankfully, but had a prolonged ICU stay due to GI bleeding, an ECMO site bleed, and HSV viremia. I'm sorry that the images covering the text there, I think, got enlarged a bit in the transfer. So he was actually discharged from the ICU, again, completely neurologically intact, 5 weeks after his initial cardiac arrest, which was great. And a repeat echocardiogram done at that time that he showed that he had quite significant recovery of his LV function, and he was feeling quite well and doing quite well. He actually had a repeat angiogram as well that showed that that our intervention was successful, at least from a coronary perspective, and still showed preserved flow both to his LAD and other major vessels there. His RCA remained occluded, but as you can see, he's developed even better collaterals now to that RCA territory. Unfortunately, while he was recovering outside of the ICU, he developed a recurrent pneumonia and eventually became septic. He was transferred back to the ICU in respiratory failure, and 2 weeks later in the ICU had a recurrent PEA arrest with a substantial downtime once again, and at this point the family decided to withdraw care. I think that this case is important because it identifies a lot of different things. In addition to the fact that that ECG was quite ischemic when the patient came in, and we know that patients with heart transplants don't necessarily feel symptoms the same way that we expect of cardiac patients, and we should always keep a very low threshold to really activate emergency services with our transplant patients. But I also thought that this case really highlighted some important parts about eCPR. So as we know that ECMO-assisted CPR is the addition of VA ECMO to active CPR, and when we talked about the for patients with prolonged CPR in the hospital, having a mortality rate of, a survival rate of less than 1%, what we do know from emerging literature is that eCPR in all comers can actually increase survival to discharge to as high as 30%, which is pretty phenomenal. There are some advantages of using ECMO in this situation over some of the other MCS devices up front. Well, the ECMO doesn't depend on adequate LV function, such as an intra-aortic balloon pump, or RV function, such as a tandem heart or Impella device, but it does have some disadvantages as well. There is dedicated personnel required to manage VA ECMO, and we do know that ECMO increases LV afterload as well, potentially increasing wall stress and ischemic demand on the heart also. But the purpose of eCPR, as we know, is not to really change the patient's underlying pathology, but it'll give us time to intervene and actually try and correct whatever their underlying hit is. And that's why when we choose eCPR, we have to do it very carefully to try and pick the appropriate patient, potentially with a reversible condition. If someone is irreversible, hopefully they will be amenable to some sort of definitive therapy or exit strategy, and hopefully they have a minimal comorbidities that are not competing with their underlying disease. We also know from literature that there are poor prognostic factors before you cannulate someone on VA ECMO during eCPR, such as having a high lactate or low pH. But one of the most important factors is low flow time. And so what is low flow time? Well, if you divide the delivery of eCPR into 5 phases, no flow time would be these phases 2 and 3, where it's literally the patient from the moment of their cardiac arrest to CPR initiation, and finally from active CPR to ECMO cannulation. And we know that if we can limit low flow time in our patients who are receiving eCPR, that they actually do much better. So in conclusion, just a couple points potentially for discussion. So we know that ECMO-assisted CPR can be life-saving. I thought it was really particularly really important to discuss the use of intra-aortic balloon pumps as a potential venting or LV afterload reducing strategy, particularly in somewhere like Canada where Impella isn't necessarily readily available at most centers, including the one that I came from. And then, as we know, determining candidacy, particularly in a CPR situation, is difficult, but also needs to be rapid and efficient. And the developing and putting systems into place to allow us to do that is pretty paramount. So thank you so much for allowing me to present the case.
So yes, this is an excellent case. I think you walked us through several elements. I have a few questions. So from an interventional standpoint, the initial cath that was done a couple of months prior to this presentation, even in that one, it seems like there is something in the distal left main. Was there any functional or anatomic or physiological assessment done at that time? Because to me, at least visually, it looks like significant enough to even consider some kind of advanced imaging or assessment. And that may have, if the patient was already noted to be positive at that time, may have prevented some of these events down the line. And then obviously the second question is, in the middle of the night when this presented, I guess about 3 o'clock in the morning, based on that EKG, this guy was clearly ischemic. He had AVR-ST elevations, reciprocal depressions. Knowing his previous angiogram, knowing his history, I think this is someone that you could have potentially considered taking to the lab right at that time. I know it was not a classical STEMI, but this was someone who was just impending shock. And then having taken this guy to the cath lab right at that moment, maybe we could have prevented all of that happening early in the morning with 15 minutes, 15 cycles of CPR. And then obviously you guys have a brilliant save on him with VA-assisted, ECMO-assisted DK crush and good results there. But eventually, as we see quite often in these patients, you can save them from the initial insult, but then other things catch up on them. And so despite everything else, he didn't have a great result at the end. But I guess my questions from an interventional standpoint, one was the functional and the anatomic assessment, and the second is why was the decision to delay activation of the lab here?
So I think those are all excellent points, because particularly after the case, you can imagine that the interventional team, we were saying, oh, how great the at least anatomic and angiographic result were. But overall, when we discussed this case, you're absolutely right that the learning points from this, in addition to the interventional and MCS portions, are the fact that back 3 months before he came to the cath lab, no interventionalist was consulted on that angiogram. It was done by a non-invasive cardiologist who changed his medical therapy. And I think we can all say already that there was a problem developing at that point. And in hindsight, if someone had been involved, we probably would have at least FFR'd both the LAD and IVUS to that left main, because as you mentioned, there's already disease starting there. But unfortunately, none of us were involved. I think the second part is that we took this case as a learning point to teach all of our trainees that not only is that ECG ischemic, in my mind, he is having a STEMI. That ST elevation and AVR is gigantic with all of the changes there, and it fit exactly with his eventual angiogram where his left main was pretty much going. So we patted ourselves on the back a little bit after the interventional portion, but we really took the time to sit down with all of our cardiology fellows. And again, to be fair, that ECG was reviewed with an on-call cardiology attending. And so there was a lot of points there. When we talked about the Swiss cheese model of mistakes, there was a lot of points that we could have learned from, and that hopefully we did.
A couple of procedural questions. Again, difficult case. I think you pointed out the more careful evaluation. In the lab, you commented upon the fact that you saw that the aortic valve had AR, clearly had elevated end diastolic pressures, afterload problems as well. I think as we've learned through the conference today, perhaps another modification would have been to do your SWAN right there, rather than sending him back to the ICU with the ability then to utilize that to make an assessment of what additional therapy you might do. Is that a teaching point that you think came from that?
Absolutely. So the center that I came from wasn't in the habit of using SWANs routinely, but again, this case also demonstrated that particularly someone who we deploy on any sort of mechanical support device, if you're in the lab already, it's not a bad idea to just put it in there when the patient's already sterile, and it's you're going to get your best hemodynamics immediately at that point, and that was also
and secondly, more controversially, is complete revascularization. I think the question, particularly in somebody like this, I think in a non-transplant patient, their tolerance of that chronically occluded, i.e. more than 3-day right, may be tolerated, but at least a consideration would be perhaps to have gone after that right as a way of further protecting it and unloading all of the stress on the left main LAD.
Dr. Tarani? My hat goes off to the interventional team. That was truly a tour de force performance in terms of getting the patient to survive, at least survive the index clinical presentation, although he had a devastating outcome. This is a question I was going to ask my heart failure colleagues. At my institution, one of the things that we do now when these patients come back for their angiograms a year or so after their transplant, they ask us to do an IVUS of at least one of the large proximal epicardial vessels to screen for CAV. Just wanted to see what the practice patterns around the country from the experts are, and perhaps whether, and again, this is obviously post fact, but whether that would change management with regard to making your immunomodulating therapies more aggressive.
So there was an enthusiasm for doing intravascular ultrasound looking for transplant vasculopathy at our center, but it's kind of softened over time because of the variable data. You were going to comment?
Same thing, because yes, it came a lot, especially when the everolimus and the rapamycin thing was coming, that almost 100% of the patients who have heart transplant at 1 year, if you do intravascular ultrasound, will show signs of early vasculopathy. And there was a lot of enthusiasm, and in fact, Mayo Clinic is still pushing the rapamycin conversion at 6 months to decrease the incidence of allograft vasculopathy. It has not been replicated everywhere, that whether it retards the progression of allograft vasculopathy or not. And that's why the practice as a whole has gone. But now there's a resurgence of a PET CT scan, which is a functional and an anatomical assessment, rather than exposing them to coronary angiogram every year, because all these patients who are on calcineurins develop some degree of renal insufficiency, and you don't want to give them contrast more and more as you go forward. And PET CT gives you a functional assessment. Whether based on that any therapy alters the course of the disease is another debatable point. There are vasculopathies of various kinds. Some of them are focal, which lends itself to percutaneous intervention with reasonable intermediate term results. But if you have diffuse vasculopathy, here we all focus on the left main, but if you saw the distal LAD and distal circ, they were diffusely diseased, and the collateralization of this was very different from a normal person having coronary artery disease, thereby suggesting there was significant microvascular vasculopathy as well. So his long-term prognosis was doomed even before you started doing the case. In fact, I and Marwan were talking that our experience was, because when you showed the subsequent echo, such a remarkable improvement, I thought, wow, they lucked out. And then you presented the next slide that he died, because that's the experience everywhere. Except for a type A focal vasculopathy sometimes, the pathophysiology of it may be a little different from immune-mediated vasculopathy. Most of them universally don't do well.
Okay.
But many centers, I don't know, I will be interested to hear from Jerry whether they go to rapamycin sooner like Mayo Clinic does, or you wait till 1 year.